In this episode of the podcast, I'm going to be speaking with Dr. Andy Bush. He is an orthopedic surgeon, and he has, in his own words, moved from fracture fixation to fracture prevention. His bread and butter was hip fractures and pelvic fractures. And now he has a bone clinic and is empowering women with education and really helping them, giving them hope, actually, is the words I hear the most often from the women that I speak with that have seen him. So we are going to be discussing a DEXA scan and T-scores and what really matters. Does your T-score really matter? And sit back and listen to this and learn if the DEXA scan is something we should continue getting to determine our fracture risk and the quality of our bones. Today on Stronger Bones Lifestyle Podcast, I'm going to speak with Dr. Andy Bush. He is an orthopedic surgeon, and his tagline is he's moving from fracture fixation to fracture prevention. And I want to have this discussion today because I'm so amazed at how many women I get on calls with that sometimes have their DEXA scan results, sometimes know their scores, oftentimes don't, but most importantly, don't even understand what any of it means. So I want Dr. Bush to give us some clarifications and some clarity around what is a DEXA scan, what do we really need to know, and what is it telling us, or what is it not telling us? So welcome, Dr. Bush.
Thank you, Debbie. And it's always a pleasure having these discussions with you. They're great. And a lot of times we come up with more ideas for future discussions. So I think probably from this one, we'll probably have another podcast that's going to result. So I do want to talk about is probably limit the discussion of DEXA to the T-score. That's ultimately what is giving you the diagnosis of normal density osteopenia, osteoporosis. And that's the number that doctors look at to say, well, you need medications because you have a certain T-score, you have osteoporosis. In my bone health practice, I actually do not use the T-scores to make that determination. I'll tell my patients that I look at the T-scores, I want to make sure they make sense. That statistically and looking for the patterns of certain T-scores as we're doing our REMS assessment, that the T-scores, again, make sense for the person who's sitting in front of me. And once I've established that, then I will not use a T-score in the decision-making because I have what's called a fragility score. So I think what's going to be important today is to explain, or what I usually explain to my patients as they're sitting in front of me, to tell them why the rest of the world might be using T-scores right now, but because I have a REMS, because I have the ability to measure structure, so that's why I don't use T-scores and the foundational reasons for that. So,
So let me just ask there. You're saying makes sense. So what does it mean makes sense? Are you looking at this woman? Who is she? What's her lifestyle? From the very beginning, are you analyzing who's that person when you say makes sense? Is that where you kind of get to with that?
Yeah, absolutely. Because with the bone health program, I do get a thorough intake questionnaire filled out by my patients. I go over, which asks them all the questions about their health and then also physical activity, exercise habits, eating habits. So I had that background. And I know the person coming to me, and again, most of my patients are healthy people who are doing the right things and they're just really looking for guidance, or they're terrified because the DEXA showed them something that they really didn't expect. So I have that background, and then with the numbers I generated from my REMS study, I use those numbers along with the information I have already on the person who's sitting in front of me. And also you can look at somebody, and I have ladies who come in who are told they're frail, and these ladies are anything but frail. I mean, they exercise, they're in good shape, they take good care of themselves. So that label of being frail does not match the person who's sitting in front of me. And the diagnosis of osteoporosis to mean fragility or to mean frailty does not apply to this woman, although her T-scores put her in that category. So that's what I mean by makes sense. Because again, bone health has to make sense. Your fracture risk is based on the weakness of the bone, and the weakness of the bone is not an isolated problem. It's going to be a health condition, which is one of many health conditions because the bones are tied into many other organ systems in the body. So again, it's an appearance of the patient, but then it's also the information I get that's in addition to the data that I've gotten from the questionnaire that they answer. So, I mean, it's a long answer, but did I answer that question?
Yeah, because that never happens. This long question, this line, but all that you're doing, that doesn't happen. It's lay on this bed, get this number, and then here's the number that everything hinges on. And you're saying it's a much bigger topic than that. There's so much more to it. And does it make sense? And so let's talk about that. Let's talk about, does it make sense? So what is the T-score? How does that determine? And what is that? Why should we care about it? What does it really mean?
So T-score is a surrogate for the density. The DEXA will measure a bone mineral density, or get a bone mineral density value. It will measure the density of the hips or the spine. And then that bone mineral density gets converted to a T-score through a statistical approach. So using statistics, you get the BMD that's being compared to, if you're between menopause and 90, it's the average density of a database of 30-year-olds, of 20 to 29-year-old white females. So using that average, everyone is compared to that, and then you generate a T-score based on your statistical comparison to that average.
Okay, but why are we doing that, though? Why is it that we're looking at a 29 or 30-year-old and comparing anybody 50 to 90 to that? Like, why is that even something we're doing?
So it's not really a perfect way, and there are a lot of individuals that say it's actually probably not the best way, but it was based on the fact that the bone mass of a younger person is maximum at about the age of 30. So that's sort of the peak bone mass, and that was determined. We'll use that as the benchmark. And then everyone gets compared to that. Now, as computational abilities get better, as AI gets better, the databases, I think, will be more broken down because there is variation in skeletons between different regions of the world. The Asian bone is very different than European bone is very different than African bone. So really, it's at some point, the databases will be more reflective of that. But right now, with the limitations that we still have in their ability to derive these statistics, then the convention is still that everyone who's between menopause and 50, or menopause and 90, and a guy between 50 and 90, we're being all compared to this benchmark, which is the average BMD of a database of 20 to 29-year-old white females.
Okay, and I guess that makes sense. So we're going to go to, when were you potentially that had the strongest bone? So that kind of makes sense.
Yeah.
But then we have to get into a place of acceptance of what should a 50-year-old be? What should a 60-year-old be? What should a 70-year-old or an 80-year-old? And then how you said, does it make sense? Then it's, what is a active 50-year-old versus a sedentary 50-year-old, or an active 70-year-old versus sedentary? And that is what we don't have as a part of a standard T-score DEXA scan.
No, it does not ask you the question of, do you exercise? Do you eat right? Statistics based on the general population. And if the general population happens to be unhealthy, that is the statistics that you're going to be assessed by, because the computer, whether it's REMS or DEXA, again, does not ask you those questions about lifestyle. And lifestyle choices have a big effect on, obviously, not just our own general health, but also our bone and muscle health.
Yeah. And so for those listening, we're using the word REMS, which is Radiofrequency Echographic Multi-Spectrometry, which is an ultrasound technology that's new and that is going to give, in our view, yours and mine, a better, not just better, but what would the word be to say that it's a more...
It's actually a different way of assessing bone, which is the model that's being developed is superior to the model of DEXA, which is really you're just blocking X-ray beams. And DEXA is determining how well does your bone block X-ray beams.
Right. So it gives us the strength and the quality of the bone, which is a better indicator, or really looking at fracture.
Or the structure of bone. It's actually listing the structural properties of bone.
And so we'll have another podcast, and we have done podcasts. You and I have done podcasts. I think my 80s, the episodes that are in the 80s, I can't remember what number, but you're like in the 85, 86, 87 episodes. So they can listen to what we've talked about with REMS. So today we're going to discuss DEXA. So let's get back to the T-score and DEXA and how it works and what we need to know.
Yeah. And again, why, as a bone health physician, why have I chosen not to use T-scores? And again, that's not necessarily in line what is considered standard of care right now. Everyone talks about T-scores. But as an orthopedic surgeon, as a REMS user who can measure structure, it just makes more sense for me that we should be looking at structure and not just density. Now, T-score is a measure of density. It was a way of converting a bone mineral density value to a value that can then be used to determine a definition of osteoporosis or osteopenia or normal density. So T-scores are a surrogate for density. And density is a property of bone. It's an important property. but it's not the only property, and it's not the most important property. Now, there are every material, Debbie and I sitting here talking to you guys, listening to us, the chairs we're sitting on, the table that's in front of me, the pen I have in my hand, everything, we all have our own properties. And they're multiple. So density is one of them, but you have specific gravity, you have conductivity, malleability, elasticity, chemical composition, chromatin content. And those are just a few of the many properties that make us up. Now, the problem with T-scores is it's actually just looking at one of those properties and trying to determine what's going to happen to something when you do something to that material. So for an example I like to use is, okay, I have this pen, and I just dropped the pen on the table, and you heard a hit, but it didn't break. Well, that's not a physical property. That's a behavior. When the pen hit the table, it interacted with the table with a force dependent on its weight and gravity, and that behavior was such that the pen didn't break. Now, if you had a thin glass rod and I dropped it, well, you would hear it shatter, because the behavior of that glass was such that when it interacted with the table, it broke apart into many pieces. So that, again, aren't physical properties. Those are called mechanical properties. That's behavior. So why are we taking a physical property like density and saying, okay, we're now going to predict the mechanical behavior based on this one property? It doesn't really make sense to do that. And those of you who might have some experience with engineering, or just anyone in the engineering world, they don't do that. They don't use density to determine whether a bridge is going to fall down, or wings going to fall from an airplane, or a tunnel is going to collapse. What they're doing is they're measuring structure. So really, to take one property, as we are doing as doctors, and saying, okay, now we're going to determine if you're going to break apart based on this one property. Again, nobody who's assessing structure in the real world like engineers are, they don't do that. They're not using density, and they're measuring the structural properties. So an example I like to give, that I give all my patients, is I use the chalk and pencil example. Now, to be able to kind of say why we can get a T-score on a piece of chalk, you can actually do a DEXA on a piece of chalk, because the DEXA the way DEXA determines your bone mineral density is just measuring how well it blocks an X-ray beam. So you're placed on a table, and an X-ray beam is passed underneath you, and the X-ray machine passes underneath you, and an X-ray beam passes through you. And there's a collimator or a receiver that's collecting how much radiation penetrated. Now, if the bone is more dense, less X-ray is going to get through. If the bone is not so dense, more X-ray is going to get through. And that's literally what DEXA is doing. Now, the mathematics and the physics, as far as how that information is interpreted, are very complex. But that's as simple as it is. You're just measuring how well are you blocking X-ray beams. And the DEXA doesn't discriminate what's blocking the beam. And I kind of kid around and say, well, you could put a brick on your stomach and have a DEXA done, and the DEXA is going to say you're as thick as a brick, because it doesn't discriminate. It's up to the examiner to say, hey, get that brick off of there. Well, that's not going to happen. But if a lady leaves a piece of jewelry on, or some metal in the clothing gets in the portion that's been examined in the gantry, that's going to affect DEXA. DEXA is going to go ahead and include that, because it doesn't discriminate what's blocking the X-ray beam. So you can do a DEXA on a piece of chalk, and we know chalk is very dense. You look it up; it's 2,600 kilograms per meter cubed. If you compare that to a pencil, wood is somewhere between 300 and 800. So chalk is 4 times as dense as wood. And if you did an X-ray on a piece of chalk, you would get a really good X-ray, because the X-ray beam cannot pass through the chalk. The chalk will block it. So if you did a DEXA on a piece of chalk, you would have a fantastic T-score. The X-ray beam would not pass through the chalk. Very, very little X-ray would get through, if any gets through at all. So you'd have a really good T-score. It'd be way up in the green. Whereas the pencil, which is made out of wood, doesn't block the X-ray beam. Now, we don't talk about the graphite or the metal eraser holder. It's just the wood. X-ray will burn right through the wood. So it's going to have a horrible T-score. It's going to be osteoporotic. Well, the purpose of this whole discussion is not to really see what your T-scores are. It's really to know if you're going to break. So let's use the T-score model that we have for chalk and the pencil to determine what's going to happen to them if we drop them. So now the chalk is in the green, has a fantastic T-score. We determine that by DEXA. And so when we drop the chalk, it should bounce. Now the pencil's in the red. It's horrible. It's a horrible T-score. When we drop it, it should shatter. But what happens is exactly opposite. The chalk shatters, the pencil bounces. So the predictive value of T-score in that model was 0. It had no predictive value. So now how can we consider it a reliable way to determine whether you're going to break if you happen to fall, a kid around happen to drop you? It's not a reliable method. So what you really want to assess, you want to assess the same thing that the engineers are assessing when they look at a building or they look at a tunnel, is what the structure is. Because it's the structure of the material that determines its strength. The pencil's not dense, but it's strong. We build houses out of pencils. We build houses out of wood. We don't build houses out of chalk, even though it's dense. Even it's four times as dense as wood. We're not going to build a house out of chalk because chalk's brittle. It's going to break. So really what we want to be assessing when we're assessing your bone health is assessing the strength of the bone, the structure of the bone. And REMS has the ability to do that with the fragility score.
Yeah, so here's the thing though, but what we are doing is just a DEXA scan. And then, you were talking about having a brick on your belly, but also if somebody has a lot of arthritis or a calcification on their spine, that's going to get in the way. If they're not positioned correctly, that's going to get in the way. And the only thing we are really using is a T-score. It's what scares the heck out of women. And there's a lot of things about the DEXA scan about, you've got to look at your hip score and your spine score to make sure that they're like in the same ballpark, because you can't have a really, really bad spine with a hip that's not in those high ranges and have that be statistically relevant. So then there's something off with it. A lot of women don't seem to know their scores when I talk with them. And even though they're told, some people are put on medications even with a negative 2.7. So they don't really know their T-score. I think that there's a lot of physicians that are not as savvy. I hope I could say that without being offensive. I don't mean to be offensive to anyone, but I do think that the interpretation of the DEXA isn't fully understood by everyone. We don't really understand it. But the problem is that there's so much weight placed on a T-score, and everything becomes determined from that T-score. And that's where the problems are.
Yeah. And the T-score was developed 30 years ago. So it's now everybody's used to it. Everyone's using it. But it really is not a good determinant. It's not a reliable determinant of whether a material is going to fail, whether bone's going to break. Because again, it's measuring the density by determining how well X-ray beams pass through it. And there's so many things that can affect that. And it's also developed in statistical tables. You have to be a certain size, a certain BMI in order for that statistic to really apply. And if you're not, then your T-scores will be, or the determination of your T-scores will be wrong.
Okay, that's important. Okay, because that's an important thing there. Do we know what the height and weight range is where we have to start thinking, there's a lot of variability, or this might not be statistically relevant? Like, is there a height or a weight that we could say?
It would be whatever average is, because the databases that are used, either the NHANES database, which is a CDC database, is a normative database. It's based on a large database, 100,000 plus women. And so when you average it out, there'll be an average height, average weight. And I'm not sure what that is in the United States, but it might be 5'6", it might be 140, 150 pounds. So that give or take, that might be around where average is.
Okay, so then when you're moving away from that, so for your 5 foot tall, 100-pound female, or your 5 foot 105-pound female, she's going to be away from the average weight. So then we might have a little bit more variability in the outcome.
There'll be a bias. And I like to use my wife as an example. That's her size. She's 5 foot tall, about 105, 110 pounds. And she has osteoporosis. She's way in the red. And she's in her 60s. Now, she's on any meds, and there's no reason for her to be in meds, because when we do this structure analysis, when we do the fragility score, she's in the green. Her bone matches the bone in people who have not fractured. So based on the model that's developed by REMS, and again, that might be another podcast, is actually explaining how REMS is doing that structural analysis. But when it does it, her bone matches the bone in individuals who have not sustained fractures in the database that's used. So based on that, there's no indication for her to be on medication. Even though she has osteoporosis. But again, according to our model, T-score models, a pencil is osteoporotic. Wood is osteoporotic, but yet we build houses out of it. So it's not dense, but it's strong. So again, this is the conversation I have with my patients, because a lot of the ladies they're small. They're smaller build, they're smaller framed. And so there will be bias even with the REMS, because the REMS uses the NHANES database in the conversion from bone mineral density to T-scores. So if they're below average size, there will be a bias even with REMS. But then we get to the fragility score and there's not a bias with that. And these ladies who might have low T-scores end up being in the zone where their bone matches the bone and people haven't broken. So their fracture risk is low. Therefore, they don't need medication.
As I'm speaking with Dr. Bush, I wanted to share that we actually put together master classes to help educate women and empower them to take control of their bone health. And one of the best ways to do this is through education. So look below to see if one of the master classes we're offering has information in it that you'd like to learn more about. And join us, and we can speak with you and answer your questions live on the spot. And we also share materials that you could take to share with your physician as you become in a equal relationship with your doctor in determining what you need to do, what course of action you should take for your bone health. Now let's get back to the show. The fracture risk is something we get from REMS. That's where we get the fracture risk. We're not getting that when we do a DEXA scan, right?
Yeah. Well, the implication of a low T-score is that you have high fracture risk. Now, there is an association, and I don't have a number. I've been looking for the number for this, but I can't find a definitive statistical number. So the way I'm going to say this is the words are chosen. If there's a group of individuals who have fractures, have sustained fragility fractures, they will tend to have a lower T-score. I'm not saying that they do, but there will be a tendency when you look at the T-scores of individuals who have fractured, they'll tend to be lower. However, another competing statement is, and this is out of DEXA literature, 50% of all fractures happen in ladies who do not have osteoporosis. So half of all fractures happen to ladies who have normal density or who have osteopenia. So now how do you reconcile that? Well, because if I just said that people who fracture tend to have lower T-scores, well, how can it be 50-50? Well, there are more people who do not have osteoporosis. The group of individuals in the general population who are either normal density or osteopenic are a much larger number than the individuals who are osteoporotic. Because you have more ladies who have either a diagnosis of osteopenia or normal density, you're going to have more fractures. Statistically, you're just going to have more fractures. So the numbers do line up. So the rate of fracturing osteoporosis is higher, but the absolute number between the two groups is equal. It's 50%. And the problem is when you look on either DEXA or REMS on the first page where you see the graph that's red, yellow, and green, and you see your target is either in the red, yellow, or green, and you panic, well, I'm in osteoporosis, I need meds. Well, based on that graph, 50% of people who break are where you are, the other 50% are in the green or yellow or above you. So how can you really determine what to do if you're 50-50? And that's an incidence graph. It's a prevalence or incidence graph. It's not a rate graph. So it sounds confusing because it is. And that's why I'm choosing not to use T-scores, because again, it's confusing, but then the whole premise of why are we using a single physical property to determine how a material is going to behave? Because the behavior is not based on one property. It's based on all the properties that a pen, that a piece of wood, that a piece of chalk, that our bones, they all have multiple properties that determine how that's going to behave when a force is applied. So that's where the structure, the strength, the quality comes in. That's why we have that conversation now, because we have the ability to measure that. REMS can measure that. And then that is a better predictor. It's a more accurate predictor of how that bone's going to behave when you apply a force to it. Will it break or will it not break?
Yeah, and what this brings up, so you started off by saying, does it make sense? And my podcast, episode 100, I had to do it in 2 parts. I actually talked about 100 contributing factors to bone loss. So if we here are just looking at a DEXA scan T-score, which is what we're doing, really that is what we do here, that's one factor. And we're not taking into account who is the person that we're looking at. What's the lifestyle of the person that we're looking at? What are the other factors? I think you and I spoke once, and I asked you because you said your bread and butter was to fix broken hips and broken pelvises. and I try to ask you, could you generalize about who was the woman that fractured her hip? I think that when we can see her, when we can understand, and this is what you told me, is that, and it's closer to the 80-year-old mark, and that usually the women that you saw had multiple metabolic conditions. It wasn't the healthy pickleball playing lady that just played pickleball on Sunday that fell and broke her hip. It is typically a woman that's usually not strong, not active, and had other metabolic conditions. So okay, you said that's correct. Sorry, I should have let you say that. So my goal is to take away that fear that the DEXA scan and the T-score gives, because it's one thing we're looking at, and we're trying to, I don't want to say poke holes at it, but rather just minimize. We're trying to soften the blow, because it is a blow. It's a blow when you get your T-score. It pulls a rug out from under you. It's disempowering in the moment you get it. And unfortunately, in our conventional medical model, the only tool that we have, the only tools are medications. So now we forget all the other factors that contribute to bone loss. And that's why I want to ask you these questions. I want to bring this clarity to women that this T-score is one factor of many, many, many factors.
Well, it's also an imperfect factor. Really, the stand I'm taking is that it's imperfect. And even though there might be pushback from the DEXA community about that, they might say that out loud, but behind closed doors, they're talking about TBS. They're talking about the trabecular bone score, which is a DEXA method added on software to measure certain. There's a way of mathematically processing information from DEXA to then determine kind of a parameter for bone quality. And if you hit a certain range of numbers, you're considered to have normal bone. If it's the middle range, it's the degraded bone. If it's a lower range, it's partially degraded and it's degraded. So even the people who are promoting DEXA and pretending that T-scores are really, really important, behind closed doors, they're panicking and they're using T-score with TBS because they realize that density is not the best way to determine fracture risk. Because again, 50% of ladies who fracture have normal density or low bone density, do not have osteoporosis. So there's a problem with that method, and it comes down to the fact that, again, you're measuring only one property. Now, it's an important property, but it's not the most important. Pencils, wood is not dense, but we build houses out of wood. We would never build a house out of chalk. Even though it's 4 times as dense as wood, it is not 4 times better. It is not a good building material because it's structurally not strong. Whereas wood is not dense, but it's strong. So that's really, we want to redirect people's attention from the T-score. Don't panic about your T-score. Now, again, it needs to be looked at. It needs to make sense. But it's not going to give you necessarily a valid measure of what your fracture risk is. To do that, you really have to look at the structure of your bone. And REMS gives you it's the best method right now to look at the structure of your bone to determine, again, do you better match somebody who's going to break or somebody who's not going to break? So really that's really what I want to leave my message. I want to leave with this podcast.
Right. And the thing is, so you've done more REMS than anyone in the US. The problem is, as of now, 2025, we don't have that many machines here. So they're starting to get more and more machines. And you're in North Carolina, so if someone is fortunate enough to be near you, they can come and get that there. But women are having trouble. I get asked this all the time, where can I get a REMS? Where can I get a REMS? So until it exists that REMS are more easy to get, which is going to happen, I don't know when, but will. Let me ask you, you talked about the TBS, the trabecular score that's added onto the DEXA. So I have never been offered that when I've had a DEXA. I think I've already I'm in my late 50s. I think I've had 5 DEXAs at this point. I've never been offered that. Is that something you can ask for? Does it make sense to ask for that? What are your recommendations on that?
Yeah, it absolutely makes sense. Now, it's hard to find because it is added on. It's expensive. And with how reimbursements are going with insurance, a lot of people who own DEXA machines can't afford it. They can't afford to purchase that because what they get paid for by insurance companies is so bad that it's economically, they can't do it. So unfortunately, it's not that prevalent. Now, some places have it. There's some individuals who have invested in it. So if you have the opportunity, again, I kind of kid around, but if a patient of mine comes and asks me for a DEXA, now I'll give them the evil eye, but I'll order it with a TBS. And I'll also go to a specific facility in Raleigh, which I think does good DEXAs, and they offer TBS. But that's otherwise, if you're just getting a DEXA, it is my opinion that you're wasting your time, you're wasting your money, and you're getting irradiated for no reason. Because the T-score is not a reliable way to determine if you're going to fracture, and that's ultimately what you want to know. And the problem is you say, well, I can't get REMS, so let me get DEXA. Well, if you're getting wrong information from the DEXA, is that really helping you? So you got to be careful with that. And unfortunately, like Debbie, like you said, there's not a whole lot of ability for ladies to get a REMS or get the structural assessment of their bone yet. So again, that's a hard question to answer, but I look at T-scores, and again, a lot of ladies come to me, they're told they need medication, they have osteoporosis. Again, that doesn't make sense. The lady sitting in front of me is not frail, yet she has osteoporosis as a diagnosis because her T-score was negative 2.7. She's being told that she needs Prolia or another medication. We do a REMS, and we get an assessment of her bone structure, and her bone matches the bone in people who are not going to break, or who haven't fractured. So she has strong bone. So when I see her as a patient, as her doctor, not only don't I want to prescribe a medicine, I would be wrong to prescribe a medicine because medications are for people with high fracture risk. If your REMS shows you that you have the bone that matches someone who hasn't broken, you have strong bone, you have low fracture risk. So medication is actually contraindicated. It would be wrong for me as a physician to prescribe medication to you. So it's a dilemma. It's a public health problem. And you're working on, I guess you and I are working on solving it, but it's a long road to go.
It is, and we're going to solve it information is queen is what I always say, because I get asked by women, because I talk about the REMS so much, and I was fortunate enough to have a REMS. I went to London and had Nick do a REMS on me. Yeah. So I'm fortunate to get that. And then people ask me, should I get a DEXA? Because you're being exposed to radiation. I mean, all the things you mentioned. So they ask me, and I'm like, I can't really direct you in that way. And I'm wondering myself, should I get a DEXA anymore? So no.
You get those?
REMS.
I used to get 2-3 years ago when I haven't done as many REMS, and obviously whenever you practice medicine, you learn how to do something, but then you do it, I guess, especially as a surgeon, you do it, and if it works, you repeat it. If you do it and it doesn't work the way you want it to work, you're not going to repeat it. So 3 years of doing REMS, I have no issues. I am swimming deeper into the REMS pool. There are issues that I'm addressing because I've done enough where I've noticed some problems, and I'm actually working on solutions for those problems or ways of explaining those problems to my patients. But they're minimal. They're not taking me away from REMS. So with that, I don't recommend DEXAs anymore. And now, if someone asks me for one, I'll give them an order if they really feel that they need it or they want it, or other doctors making them get it. But I'll really tell them that, again, you have to get a TBS. Otherwise, you really are wasting your time, your money, and you're getting that radiation for no reason because you're getting a measure of one of the properties of your bone, not necessarily really reflective of what your bone's going to do if you hit the ground. How is it going to behave when you hit the ground? The density does not necessarily tell you that.
Yeah, so all this education, what it does is it gives women power. So empowering women is my goal. It's also yours, I know as well. We're giving women information that they can then make their decisions. So getting a REMS would be ideal. And if you can't get a REMS, get a DEXA scan with a TBS, ask for that. So we're giving you the information. So REMS, if you could find it, I could help with that as well. So if someone contacts me, I can help to tell them where to get it because there's certain facilities that have it. But the REMS would be optimal. If you're going to get a DEXA with a TBS, a trabecular score, that you can ask your physician to. So we're going to be like pissing off all of these doctors. Like, why are people asking me for these things? And why are you asking this? You just need to listen to what I say. But education is really what our goal is here. And so that would be ideal, is to get all that. And so hopefully we've shared some information. So let's just come to the top of some of what we said. You started off by saying, does it make sense? And you use these words. This is why I wanted to record this podcast. You use this word about properties, that there are physical properties. That would be the T-score, right? The density is the physical property. But what we really need to understand is, when you drop something, is it going to break? What's the fracture risk?
What's the behavior?
The behavior. Yeah. So that was then the mechanical properties and behavior. I loved how you said that. And as a yoga therapist, I started to think about Do you have flexible feet and flexible ankles? What's your balance like? What's your joint coordination like? Do you have the hydrated tissue? Do you have other healthy parts to you? And the more that women can understand that it's not just a T-score, it's not just bone density, that there are better diagnostics, that's the information we're sharing. And hopefully in listening to this podcast, I'll get a lot of feedback from this and hear what I think we did some empowerment here, and that was the goal of this podcast. So any final words you want to say?
Yeah, I mean, this is wonderful. I mean, again, we started by actually just having a chat and decided to do a podcast. So I think this is great.
Yeah, it's great. You're like, this is how I explain to my women how this. I said, okay, wait. You've got to take it to the kindergarten level. And then I thought, wait, women need this because I am referring back to my, podcast I did with you 6 months ago or 7 or 8 months ago. And I'm like, well, I need a modern podcast, but really the DEXA is what I want to talk about. And that's what we did talk about.
Yeah.
Because I'm amazed at how little women understand about what their DEXA scan is telling them. They don't understand what the numbers mean. And most importantly, they are disempowered from that information that they don't even understand in the first place. And they're sitting there not knowing what to do. And so hopefully now they have some information to make some informed decisions and choices.
Yeah. Well, thank you for sponsoring. This was great.
Yeah, thank you. Thanks for joining me on Stronger Bones Lifestyle. Are you ready to take charge of your future? For show notes, resources, and information on my programs, please visit DebiRobinson.com. If today's episode empowered you, be sure to subscribe, leave a review, and share it with someone who needs it. Together, we're building stronger bones and stronger lives. Take care, and I'll see you in the next episode.